Hi, my name is Becky Sanders. I am the Program Director for the Upper Midwest Telehealth Resource Center. Thank you for joining us today. And as Matthew said, he is our presenter today, and he is from Purdue and will be talking about security and risk assessments. The webinar today, we do ask that you use primarily the Q&A function at the bottom of your screen or your Zoom window to ask questions. That way, if there's some we don't get to, we've got them recorded and we can send those out. We will be trying to make things interactive, so there may be some questions throughout, and you'll be asked to enter in the chat and respond that way. And as with the recording, we will post it on our YouTube page and also on our archived webinars page. Matthew will be making his slides available in a PDF format. So give us about a week to get those done and posted, and we'll send out an email to everyone when they're ready. So Matthew, without further ado, take it away.
Thank you, Becky. Well, let me share my materials here. Like Becky said, I am Matthew Crane, and I'm a Senior Information Security Analyst with Purdue's Technical Assistance Program. For Purdue Healthcare Advisors, I work on cybersecurity projects focused on IT security risk management. And for CyberTap, I do cybersecurity project development, quality assurance, and I'm involved in curriculum development and instruction in IT security professional education. The use of telehealth technologies has spread throughout the healthcare industry at an incredible rate in the last few years. While adoption was already on the rise, the COVID-19 public health crisis has rapidly increased that adoption rate. And while accepting the risks associated with such a rapid adoption of technology was justified by the needs of public health, it's time for us to take another look at the way we interact with those technologies to ensure that they are implemented in a way that meets our legal and ethical obligations to our patients' privacy. Information security can be a very broad subject. For today, we're going to try to get a handle on its implications for telehealth by breaking it into 5 topics. We're going to cover the 3 main types of telehealth technologies and describe the security responsibilities that accompany them. We'll make the case that in spite of the challenges that they present, telehealth is too useful an opportunity to ignore. We'll describe the types of tasks you need to be taking to manage the risks associated with the use of telehealth in your practices. We'll discuss some example scenarios of how organizations can implement telehealth in a responsible and secure way. And we'll present some general advice to take with you while you consider how you might use telehealth to care for your patients. So what telehealth technologies are we talking about? The first type is real-time communication, like, say, we're doing today. The most common examples are audio and video teleconferencing. It could be communication between patients and providers or other staff, or between providers and other caregivers and other facilities. The devices involved can vary greatly, from desktop or laptop-based video conferencing to cellular devices. And we could be talking about wired connections, cellular, Wi-Fi, Bluetooth, or even GPS technologies. When we start to talk about securing these technologies, we should take a moment to define what we mean by security. Generally, when people hear security, they think confidentiality, that is, keeping private things private. But for security professionals, security also implies protecting the integrity and availability of information. By integrity, we mean the assurance that the information is true and correct, and availability covers the concern that the involved parties can get to the information when they need it. From a security perspective, real-time communication is among the easier scenarios to handle, primarily because little information gets stored in these activities. That limits the security concerns for these technologies to protecting the confidentiality of the communications at and between the ends, and ensuring the integrity and availability of the communication channel to make sure it works well enough to be useful. While we're defining terms, let's acknowledge the specter of Hipaa hovering over this conversation. Even in telehealth, providers are required by the Hipaa security rule to implement controls that'll protect their patient's privacy, but the legal requirements for those controls end at the patient's endpoint. In other words, you aren't legally required to care about the patient's privacy after your communication reaches their location. But your patient's privacy is just as much a legitimate healthcare concern as any other aspect of their care. That means you have an ethical requirement to consider the privacy of the patient's environment, just as you would in a conversation with a patient family member in a public area of a healthcare facility. Next is information sharing. That's a very generic heading for this technology. Here we're talking about the ability for providers to store, transmit, and collaborate on information that they've acquired. This capability is the most common kind of telehealth technology already implemented in the industry. Examples could include X-rays, MRIs, recorded videos, data captures, or entire patient records. These technologies present a more complex environment for security considerations. In addition to the concerns that we described for real-time communications, we also have to think about confidentiality, integrity, and availability of the data stores. That's the places where the information resides, such as server databases, device hard drives, USB drives, thumb drives, etc. As I've said, just about every healthcare organization has been sharing information in a concrete way for a long time, but very few healthcare organizations think of it in telehealth terms. And that might explain why there are so few protections in place for these capabilities today. Patient records are routinely faxed between locations, which relies on the honor system for security at the destination. And unsecured email is commonly used to transmit sensitive information. I can tell you today that we, as an industry, aren't doing a great job at this. Every client that I've visited this year has had unencrypted data stores in production environments, and most of them have no backups or redundancy in place. Remote patient monitoring is one of the most exciting of the telehealth technologies. While there isn't a great way today to get an MRI from a patient in their home, the proliferation of smartwatches, pedometers, glucometers, and other monitoring devices provide access to a wealth of other diagnostic data from remote patients. But just like the information sharing added more security concerns than those required for teleconferencing, RPM adds integrity and availability concerns for the patient environment. And meeting all of these concerns is difficult. Most healthcare organizations will be uninterested in or incapable of providing security and technical support in the patient's home. This has led many practices to rely on the patient's consent to manufacturer or provider releases for liability reasons. And in some cases, those releases are an acceptable minimum standard. But the Hipaa requirement is for reasonable security controls, and there are situations where liability releases do not meet that standard. Just getting a consent means expecting the patient to shoulder the burden of information security, and there will always be some patients who, for various reasons, are unable to make meaningful privacy choices. So, telehealth offers a lot of opportunities, but can also present a lot of challenges. If it's so challenging, why are we even talking about it? Well, because there are so many benefits that telehealth can provide. Telehealth can give patients access to providers that may have been too far away for traditional care, and that flexibility also allows for consultation or collaboration with multiple providers. It can also be significantly more convenient for patients than traditional care models. There's no need to endure travel. And for those patients unable to travel on their own, it eliminates the need to arrange for transportation. And because those concerns aren't an issue, scheduling is easier too, and there's no need for them to suffer the indignity and hassle of waiting rooms. Because patients are in their own homes, they have easy access to things like home medication information, so providers can get better information and make better decisions about their care. And most pertinent to the COVID-19 public health crisis, telehealth can reduce or eliminate possible exposure to outside vectors of infection. Providers can also enjoy many of the same benefits that patients receive from telehealth. Telehealth means that providers need not necessarily be in the office to care for their patients or collaborate with their peers. This eliminates their own travel time, the risks associated with exposure to their patients, and the risk of cross-contamination between them. Access to patients in their home environments also means patients will be more comfortable than they would be in the office. So providers may be able to get much better information than they would ordinarily. And the convenience that patients enjoy translates to reduced risk of no-shows. That, combined with the possibility that providers may be able to reduce or eliminate the expenses associated with office spaces, promises some real improvement to efficiency and costs. When we talk about threats and risk associated with telehealth, there are three primary areas of concern: governance, platform security, and infrastructure security. And we're going to spend some time on each of those areas in the next few slides. For our purposes today, we'll define governance as the framework through which a healthcare organization is accountable for the processes and procedures they use for business and patient care. To be accountable, an organization needs to be able to compare measured real-world activity of the organization to the decisions that the organization has made about how it is going to operate. For that to happen, the organization has to consciously and explicitly make the decisions about how they operate. In other words, they need to do two things: develop policy documentation for their processes and collect, store, and analyze information about how the organization actually operates. Some of that data collection can be automated. Most EMRs generate an audit trail of each account that accesses a particular patient record. But some of that information has to be generated manually, and those required activities must be documented in policy as well. I know no one is particularly excited about creating and maintaining policy documents, but it is impossible for governance to proceed in a meaningful way without policy documentation in place. So how do we approach the governance tasks for telehealth? Well, here's a top-level checklist. By technology standards, I mean the tools that your organization has selected for telehealth activities, like which application you'll use for video conferencing. Have you made the decisions about what tools and technologies are appropriate for those needs? And are those decisions documented in policy? What controls will you use to monitor those tools in your environment, either procedural or technological? Security and privacy standards refers to how you, and more specifically your staff, will operate those activities and tools in a safe and secure way. Have you put together the policy documents for those procedures? And while not all staff members may be involved in telehealth activities, do all of those that will be involved have access to that documentation? And patients too, if appropriate? Regarding security and privacy standards requirements during the public health crisis, the Office of Civil Rights has put together some guidance available online. Let me copy that. I will share that in the chat at the end of the presentation. The short version is that OCR has decided it will not penalize you for using telehealth technology that wouldn't ordinarily meet Hipaa requirements, as long as those violations were made in good faith and no public-facing applications are involved. Finally, training. What do you need to be able to train and support the staff's use of the telehealth platforms that you've selected? And more to the point, what does the staff need to be able to train and support the patient's use of those platforms? Remember, most small to medium-sized practices aren't going to have a help desk for staff, let alone one that they can direct patients to. So telehealth staff may need to be ready to troubleshoot the most common technical problems they expect their patients to face. By platform security, we mean the protections for the applications and technologies involved in telehealth. Now, because governance deals so much with human activities, you might expect platform security to be entirely technical. But while technology is involved, the way that staff will interact with that technology is just as important. The main risks that you face are misconfiguration and the use of unapproved technologies by patients and staff. And there are a lot of different kinds of activities that are necessary to mitigate those kinds of risks. First up, you need to do an honest assessment of the way you've implemented each technology in your organization, or the way you plan to implement a future technology. Did it get implemented the way you planned? When evaluating implementation, remember to consider all of the environments in which the platform will be used. With telehealth, this means you have to include remote sites, employee equipment, and the patient's homes just as much as you would the office environment. And any implementation will require security controls. The passwords on video conferencing accounts are an obvious example, but not every situation will be so obvious. Each technology platform deserves a review of what security controls, technical and administrative, have already been implemented or will be required, and whether those controls are functioning appropriately. Security versus usability is a subject worth some further discussion. Security professionals have, and I think undeserved, reputation for ignoring usability concerns in favor of security. And there could be a lot of reasons for that reputation. I think the root of it for healthcare is, in the past, security wasn't really on anyone's radar. So security professionals have to work against established attitudes, tendencies, and procedures, all of which may have built up over decades. That can lead to a very adversarial culture between providers and IT. But usability is critical to security. If staff find the technologies too difficult or unpalatable to use, they'll do whatever they feel they need to, sabotage included, to meet their patient care goals. And that's one of the reasons why staff have to be included in stakeholder discussions about existing or potential implementations. Line staff are, bar none, the most useful stakeholders for identifying problems and pain points in the procedures that we implement. They're also invaluable in identifying shortcomings in the training programs that are necessary for technology projects to succeed, though generally that means monitoring and assessing staff activities rather than conducting interviews. Infrastructure security is similar to platform security, but it looks in another direction. Platform security concerns itself with the tools that patients and providers require, but infrastructure security refers to the devices and technologies that interconnect and support the telehealth platforms, such as networks and telecommunications, as well as the smartphones and computers that form the endpoints. Infrastructure security is what most people think of when they hear information security in healthcare. And infrastructure security is already a complex situation for healthcare organizations to manage. And telehealth can only add to that complexity. Each additional telehealth platform is an increase to the surface that the security will have to defend from attackers, and an additional workload that the infrastructure will have to support. And that last isn't a trivial concern. Video conferencing applications can use a large amount of network bandwidth, and a small rural provider's internet access may not be set up to handle that additional load. The only useful strategy for mitigating the risks associated with infrastructure security starts with risk assessment. No organization has infinite resources, and security can be expensive. It's critical that your organization identifies your most pressing security needs so you can spend those scarce security dollars most wisely. Many of you already have a risk assessment strategy in place, but even though formal information security risk management procedures have been a regulatory requirement ever since the passage of Hipaa, many healthcare organizations still don't include information security in their risk assessments. If that applies to you, please contact a reputable outside party, such as Purdue Healthcare Advisors, to assist you in building that capability. Once you have a firm grasp of the risks you face, you need to discover how well you're already managing those risks. That means an audit of that infrastructure for misconfigurations and vulnerabilities. Any issues that are identified can be prioritized for immediate action. And the work doesn't stop there. Fixing holes in your security today will not prevent new holes from opening up later. Risk assessments and audits are useful initial steps towards developing a vulnerability management capability so that you can monitor your information infrastructure and close vulnerabilities as they occur in the future. So, before I get into the example scenarios, a disclaimer. I'm going to use scenarios that include real-world vendors and products. I'm not doing that to persuade you to buy those products or do business with those vendors. I just want my examples to be specific enough to show how this challenge is complex but doable. Purdue Healthcare Advisors does not make recommendations for specific products or business partners. So that's it. Our first example scenario is a 2-doctor practice in a small town in April of 2020. The COVID-19 public health crisis has hit, and they know they need to rethink the way they'll care for their patients in the near term. The biggest challenge they face is budgetary. With the future so uncertain, now's not the time for them to spend money. On the Health and Human Services website, they read that OCR won't be enforcing Hipaa security rule violations for private telehealth solutions. So they decide to use Apple's FaceTime app on their iPhones for at least some of their patient interactions. Their first step is to document that decision in their policies. They reference the OCR Enforcement Discretion Advisory. They describe the situations when they'll make use of the app, including the planned procedure for calls and documentation. They list the types of information that they will manually capture to add to their patient record. They also note that they will either review this policy again in a year or end the use of the app at the expiry of the discretion advisory, whichever comes first. Next, they reach out to their patients. As the next appointments draw closer, their office manager makes calls to confirm appointments and also asks if the patient can or would like to stay home and meet with their doctor over FaceTime. For the patients that are interested, the manager updates the appointment to reflect the switch to telehealth, confirms the patient's contact information, counsels the patient on how to protect privacy during telehealth appointments in the patient's home, and documents the patient's verbal consent to the procedure. At appointment time, the manager calls the patient and documents the call. They note the time of the call, the doctor and the patient's locations, and that a meeting is over FaceTime. They then transfer the call to the doctor. To schedule follow-up care, the doctor can transfer the call back to the manager to complete the encounter. Our next example scenario is a slightly larger practice looking to add telehealth capabilities to their portfolio. Specifically, they'd like to add video conferencing and secure email services to their standard procedures. After some investigation, they identify Doxy.me's web-based platform for their video conferencing needs and Virtru for secure email. The first thing that they do is a simple risk assessment of those two services. Doxy.me uses a web client for their service. Because it's web-based, there wouldn't be any change required to their infrastructure. And it also means that neither they nor their clients will need to patch or update the application on an ongoing basis. As far as security goes, the public information that that vendor provides on their website describes reasonable precautions, and it was updated recently, both of which are reassuring. They conclude that the only significant risk to weigh for this service is the subscription fee, which will probably be easily outweighed through billing or reimbursement. Virtru would use a browser extension to interact with their existing Gmail email client service. While Virtru doesn't require any infrastructure change, A browser extension is a separate piece of software. It'll need to be installed on each device that they use for secure messaging, and it'll have to be monitored for updates and patching. Virtru encrypts the whole communication chain from sender to recipient, as long as the sender selects the secure message option when they start the new email. If not, Gmail reads the message before it even gets sent. But that risk can be managed with some staff training. They conclude that with minor concerns, ongoing service fees are the only significant risk with that service as well. Only some uses of secure email services will be billable, so some of the service fee must be accepted as a cost of doing business. Business and legal matters come next. They reach out to each vendor to get contracts and business associate agreements signed, and they start budgeting. They've got 10 employees that may need to use these services. Doxy.me will cost $42 per provider per month, billed yearly. Virtru will cost $79 per month for 5 users, billed yearly, or $249 per month for 25 users. They decide that only front office staff will handle secure email and no other staff will handle PHI over email at all. That allows them to select the least expensive plan. They also add $30 per month to their IT budget to cover unexpected security and maintenance costs. Next comes policy documentation. Just as with the first example, they document the scenarios that they plan to use telehealth to handle, the procedures for employees to follow in those scenarios, and the information that will be captured. Some types of information will be captured automatically by the applications, so the policies reflect what, if anything, needs to happen for that data to be incorporated into the patient record. Any data that has to be captured manually gets specified here. Once policy documentation is in place, employee training is planned. Each employee that will use the telehealth platforms has to read the relevant policies and sign off on them before they can log in and use the new systems. The practice also arranges for short one-on-one sessions so that employees can practice using the new systems. In particular, they go over how those employees will either troubleshoot issues for patients or refer patients to the vendor support resources when it's appropriate. Finally, the practice contacts their website hosting company to arrange for their website to be updated with links to their new video conferencing service. Patients that are interested in telehealth over video conferencing can sign up on the website or ask about the service when calling to schedule an appointment and be directed to the website. Either way, patient consent gets documented when signing up for the service. And our next scenario, we'll take a short break while I get some water in my mouth. For this scenario, we're going to just skip ahead 6 months or a year with that same practice. Things have been going pretty well for them in telehealth, so they've decided to add remote patient monitoring services. Because they have patients in some rural areas, they decide that the devices that they use need to have cellular connectivity capabilities. They decide to look at health mode. Once again, they do a simple risk assessment. Remote patient monitoring devices could add some complexity to the organization's responsibilities. In this case, all of the data from the devices goes first to the vendor, and the practice will only access that data from the vendor's portal. So no infrastructure security changes are needed to handle that data flow. But physical devices do have some other risks related to administration and logistics. For the first 8 months of use, each device will effectively be leased from the vendor. After that point, the device will be owned by the practice. Because the devices may eventually be owned by the practice, they each will need to be added to the practice's hardware inventory records. Assuming a BAA, the practice probably isn't responsible for the security of the communication channel between the device and the patient's home and the vendor's infrastructure. To meet their ethical responsibility, they contact the vendor and learn that the device's connections are encrypted to maintain confidentiality and integrity. The risks for this service are more complex than the previous ones the practice has considered. There are no upfront costs for the program, either device or service fees, but the costs on the back end are driven by program use. Each daily reading or patient interaction with the vendor is billable, and the vendor charges a per use fee of about 50% on a monthly basis. This means that the program costs are more difficult to predict, but they should be outweighed by billing in all cases. Business and legal matters. They reach out to each vendor to get contracts and BAAs signed, and they start budgeting. The practice will have to make an estimate of the total patient encounters with this service each month to make a prediction about the security-related administrative costs for their budget. For 100 patients, the vendor's revenue estimates suggest that the practice should budget about $600 a month for unexpected security-related administrative and maintenance costs. Next comes policy documentation. Just as with the preceding examples, they document which patient care scenarios will be managed with RPM, how providers will interact with the services in those scenarios, and what and how data will be captured. Some types can be imported in real time by the EMR. Some would get imported in a monthly upload. And of course, some administrative information may need to be captured manually. They also document how devices will be distributed initially, possibly by the vendor, how they will be collected after patient use, how they'll be redistributed for later patients, and how they'll be tracked in the practice's inventory. Employees read and sign off on those policies and get scheduled for vendor-provided training with the new systems. RPM device deployment is similar to other kinds of patient care procedures. The provider specifies a treatment plan and obtains a patient consent. The differences in this case are that devices have to be distributed to the patients and inventory records have to be updated and maintained. In the last few slides, I've given some examples for how a practice could handle telehealth security in specific situations, but I'll be the first to admit I can't predict every situation that you might face. So let's talk about some more general advice. First, financial. Avoid reinventing the wheel. There are already hundreds of new vendors and products out there that can do 90+% of whatever goal you have in mind. Take the time to research your options and pick out the one that best meets your needs. Figuring out how to make an inexpensive product do something it wasn't designed for may end up much more expensive than a pricier product that does just what you need. Also, have security in mind from day one. And what do I mean by that? This isn't an IT security example, but here's a good analogy from the infection control department: wireless keyboards and mice. Keyboards are gross. In 2010, a regional hospital in Indiana captured samples from keyboards around their facility, and 50% of the samples that they cultured tested positive for MRSA. And that percentage has only gotten worse by today. Wireless keyboards and mice for each worker in a shared office space might be a great way to handle that infection control issue. Since employees won't share those keyboards, they won't spread their germs around. But wireless devices also need batteries, and a pair of AA batteries doesn't seem like a big expense, but 30 pairs every 3 months, if they even last that long, is a more likely figure to try to budget for. At some point, rechargeable batteries will make much more sense. They'll cost less in the long run, and there'll be much less waste. And if that's the case, why start out paying for both of them? Start out by buying and using the rechargeable batteries. Now, I don't mean that you should always start out by paying for the more expensive option, whatever it is. but there's real value in taking the time to think through what the long-term consequences of your decisions might be. And that's particularly appropriate when we are talking about security decisions, because security can be expensive. As a general rule, you should estimate an additional 10% for security concerns when you're contemplating the cost of any new system. Just like I can't predict what situation you're going to face, no vendor will have been able to predict all of them either. And even if the solution you find has every feature you will ever need, your staff will still have to learn how to interact with it and incorporate those new procedures into their routine. And that costs money too. Finally, ensure that you're billing and getting reimbursed appropriately for telehealth services. All of these services have associated costs, and with all of the financial pressures that affect modern healthcare, it's critical to make sure that these services are helping out your bottom line, not weighing it down. I've already touched on policy documentation in other slides, but I also want to highlight how telehealth interacts with the patient record. Telehealth activities need to be documented just like any other procedures would be. But some of it might be new or unexpected. Many telehealth technologies can automatically capture and counter data, but if your solution doesn't, and that data needs to be in the patient record, then your staff will have to manually collect it and to continue to collect it while those requirements exist. In general, humans are bad about continuing to do things. So if it isn't obvious, you should try to find solutions that will automatically capture as much of the required data as possible. A special aside about chat transcripts. Lots of conferencing apps will include a chat function, and it's often possible to capture the chat transcript for incorporation into the patient record. You will need to make your own determination as to whether that's appropriate for your specific situation. When you're making that decision, remember that you are required by Hipaa to have a documented plan for how you'll protect each piece of data that you collect, paper, electronic, or otherwise. So each piece of data could add to that security burden. The most general recommendation there is to identify what data you will absolutely need to meet both your patient care and your legal obligations, and keep nothing else. No matter the situation, the communication channels you use for healthcare have to be secure. And by secure, I mean protected with strong encryption methods. Now, many of the kinds of services we've been discussing already use encryption to protect their communication. But if you aren't positive that the provider's connection to a service is encrypted, that means a VPN is a requirement. And while we're talking about secure communication, text messages are not. To be clear, cell phone text messages have no security of any kind. And I read last night, on top of there being no security for cell phone text messages, one of the infrastructure providers who manages text messaging services for the big cellular providers just announced that their service had been breached for the last 5 years of service. So text messaging over cell phones has to stop now. Cellular text messaging for healthcare is prohibited by the Centers for Medicare and Medicare Services, Medicare and Medicaid Services, and the Joint Commission. Now, secure messaging apps do exist, and per CMS and the Joint Commission, they are acceptable for internal communication as long as they aren't used for patient orders. That would have to be through CPOE. Storage devices have to be encrypted, whether server or desktop, internal or external. And some of these are obvious. A laptop that gets lost could have had any patient data on it. So you could, in theory, have public reporting requirements for your entire patient database. But if all of your laptops are encrypted, then even if you know that every line of information you ever collected about your patients was on a laptop that was lost, you wouldn't have any reporting requirements at all. Taking the time to get those devices encrypted is absolutely worth it. But that doesn't stop with laptops. Even printers are able to store data these days. So you may need to work with manufacturers to identify those machines and make a plan for securing them. Every device might be able to expose you to the risks of data storage. So each one needs to be encrypted. In a sense, all of this advice is risk management. These last two items just don't fit ideally into other categories. Don't rely on OCR's enforcement discretion. Enforcement's relaxed now, but you may not have enough time to implement security controls when that discretion ends. I promise you, you will not be able to afford to be a target when OCR decides to make examples after the crisis ends. And bring your own device policies should be considered very cautiously. Many larger organizations with huge amounts of money to spend still find it shockingly difficult to implement BYOD programs while meeting all of their security goals. It could be much cheaper, safer, and simpler to send a remote worker home with a pre-configured work laptop than it might be to confirm that their home PC and network environment are secure enough to meet your needs. And now, what thoughts or questions do you have for me? If we run out of time in the hour today, I'm happy to hear from any or all of you by email. So
Thank you, Matthew.
Open it back up.
I've been around this topic a lot and I learned things. So that's always, I always appreciate that. I know that it's impossible in this field to know everything. So I love when I'm able to pick up new nuggets.
Good. That's what I love to hear.
All right, so this is the interactive time where everyone else on the call asks questions.
And right now we're getting crickets. Does that mean every single question has been answered already? In which case, great, though I think it's a little implausible.
Yeah, so what you were saying about text messaging,
yes, please,
really caught my attention. I know there are some text messaging programs that are supposed to be HIPAA compliant out there. Do you want to talk about any of them, or are you here to say, nope, they're not?
No, so I'm happy to talk about them. I'm not happy to speak to specific examples.
Sure.
Essentially, just like any other app or technology or decision that affects IT, you should look at it and do a risk assessment for you. If that service claims to be HIPAA compliant and you can get a signed BAA to that effect when you do business with them, then it's probably a reasonable choice for your practice. But having been said, I use words like practice, we use words like probably as a sort of sea anchor here. Zoom, for instance, at the beginning of this crisis became the go-to choice for so many organizations because it was freely available and purported to have security. And very obviously, they got burnt quite quickly when it became obvious that Zoom's security practices were wholly inadequate, particularly for a HIPAA environment. So any service, technology, product, or vendor that you decide to do business with, you have to add them to your ongoing worries. You have to add them to your list of keywords when you're searching for what is going wrong in the news today that you have to keep an eye out for. What's a good example? A good example of one that looks like it could be a good choice and is actually a terrible choice is Apple's iMessage app on iPhones. iMessage, by default, secures every message between you and your intended recipient. And I can't say it's impossible to break those kinds of security, but it's not super likely. So it sounds on the face of it that it might be a good choice for these sorts of small providers who need to make easy, inexpensive decisions whenever possible. But I said it encrypts every message by default. It doesn't encrypt cellular text messages. So if the person on the other end of the conversation happens to be not using an iPhone, for instance, those messages start out being sent in the clear so that any eavesdropper would be able to read them. And when I say eavesdropper, I mean ham radio enthusiasts. That's the level of no security that we're talking about. And even other people that use iPhones and iMessage might at that time not have a good Wi-Fi connection. And so those text messages, instead of getting routed through Apple's secure systems, get dumped on the cellular system as well. And so you can't know at the beginning of a message whether that message is going to get encrypted or not. So yes, do your due diligence, look at those services, find out what security they offer. If the terminology that they use on those websites when they're describing their security practices isn't immediately obvious to you, understandable to you, get somebody you trust to walk through it with you and explain what it means for you. And there are lots and lots of opportunities for that. I volunteer for that service for standard one question sort of interactions. I'm going to do that for free in perpetuity while I am in this sort of role. So reach out to me. Yeah. If you're typing it on your phone, make doubly sure you're using some sort of secure messaging app before you ever hit send, because cellular text messaging in general is terrifying from a security perspective. So what other questions do we have? Where can I find the rule on not using text messaging? There is a source to quote from. Let me grab that for you. Say a lot while I'm looking for that, which is obviously great radio, but a little bit unavoidably while I scroll through my resources. Where did I put those links? Yeah. So OCR has put together some guidance online at I'm going to put that in the chat here.
Awesome, thank you.
Put together some guidance at that location and at that location. Those two have got some information about what you need to think about doing regarding text messaging, regarding OCRs, enforcement directives. Specifically, the rule about not using text messaging, you're certainly welcome to cite me, but there should be a better source for that one. Yes. Here is the next one. There is a link to the Hipaa Journal article. And I would point out that at first, the Joint Commission stated that no text messaging of any kind, secure messaging apps included, was acceptable in healthcare situations. That they have extended it to some uses of secure messaging apps are acceptable is largesse. It's generous on their part. So that there is a good quote on that particular score. And I'm fairly certain that article has some other references in it if you look it up. So thank you for those questions. Yes. In the PDF of this presentation, when we get out, there's going to be a number of references at the end of it that you guys can look up and peruse, which should help to back up some of these topics. Anything else?
Well, in your first set of URLs, was that meant to also address using a personal computer when working remotely?
Not directly.
Okay.
I don't actually have a good source
Okay.
for how using a personal computer would be a challenging situation in healthcare environments. I'm going to apply to myself for that particular authority. In the 2 years that I have been working for Purdue Healthcare Advisors, I have seen a few different organizations who are making use of bring your own device sort of arrangements, and none of them have done anything even like an acceptable job of securing those devices. If you're doing healthcare business on personal equipment, then exactly the same kind of precautions that might be necessary in the office environment are required by law in that home environment as well. And the chances that a particular employee is going to agree to let the organization's IT department get their grubby mitts on their computer aren't particularly high. And even the ones that think to themselves, yeah, I mean, I'm willing to beef up the security a little bit, probably aren't thinking of all of the steps that might be required. The device must be encrypted. The communication channels between this device and any potential service have to be secured. Activity on the machine may need to be monitored on an ongoing basis. Those are just some examples of some of the things you might need to be thinking about when you're thinking about securing the devices in your environment, and getting employees to submit to that level of scrutiny and control. I can tell you now, I don't want to do that on my personal devices. Don't get me wrong, I have a pretty high opinion of how well the devices that I own are secured. I simply don't want my employer to be making those decisions for me. And I feel that that's a reasonable feeling for me to have. And it's reasonable for your employees to have that reluctance too. And so it might just be much more reasonable to decide to provide your own equipment for your employees to use for those business purposes. Yes, I realize that might be.
Yeah, and with the caveat that the employee using a personal device is only doing work stuff on there when connected to the server. So it's
Right.
Even when they're just working through that secure connection to the server, you still have those same recommendations.
So So whenever I hear the word server in these conversations, I get a little bit nervous simply because there is this assumption about the way things work. There's this assumption in anybody interacting with IT about the way things work that doesn't actually bear out in real life. And it comes up a lot when we're talking about cloud-based EMRs, for instance. If you have a cloud-based service, that means that your patient records are on the cloud service provider's servers. And when you look at the patient records, you're looking at the information on their servers. That is emphatically not true. That's the experience that you enjoy while you're interacting with that service. But the only way for you to look at information is for a copy of that information to have gotten through the internet to your computer. And so that patient information travels from the cloud service provider every time and lands on your computer. And you're relying on that vendor's programming skills to make sure that the program cleans up after itself perfectly every time. And I can tell you right now, your cloud vendor may have done a perfect job at this, but if that's the case, they are the first organization in human history to have done so, up to and including the first humans who were making fire in their caves. And so you have to assume that your patient data has landed and stuck around behind the scenes on any computer that you've ever looked at that patient information on. And you have to assume that if that device gets lost, you may have reporting requirements on that device. And if we're talking about personal equipment, that's included. You might have reporting requirements about personal devices that you don't own or control. And so that's why I say you have to think about those situations cautiously. They might be the only affordable decision for your organization. And if that's the case, you have to do what you need to be able to operate. But you have to make those decisions cautiously and consciously. So many of the decisions about the way that we operate on a day-to-day basis just get made unconsciously, and the stakes are too high for unconscious decisions in these topics. So,
all right, thank you.
So welcome.
I don't see any other questions popping in. Now is the time for Carolyn to put in the chat a very quick survey. We appreciate your taking a couple of minutes to do that. Since we are the Upper Midwest Telehealth Resource Center is a federally funded program, we always are asked by HRSA to report back to them on our activities, and it also helps us to make sure that we're hitting the mark in our topics and gather ideas for future topics. So once again, Matthew, thank you so very, very much for coming and presenting to us today. This was exactly the information I was looking to share with our audience.
You are so welcome, and thank you so much for giving me the time to speak about this subject that I'm passionate about and that we all need to be doing a better job on. So thank you so much. It's been a privilege.
All right. Thank you everyone for joining us today, and have a great rest of your day.